Kia ora tato. Today we're going to learn about non-neoplastic GI. These are the key conditions that you have to know about. I know that you have learned a lot previously about inflammatory bowel disease. These are your objectives from ELM, and you can see that Crohn's disease and ulcerative colitis were covered quite a lot. If we look at your slides, you covered the pathogenesis of Crohn's disease and inflammatory bowel disease in general. You covered the microscopic appearance of Crohn's disease and its complications. You covered the extraintestinal manifestations of inflammatory bowel disease and also discussed inflammatory bowel disease and malignancy. Here is a table that compares Crohn's disease and ulcerative colitis. And if you are more visual, this is also from your previous notes. Because you've done so much on Crohn's disease and ulcerative colitis, and you're going to cover them again in the homework, we are not going to spend time on them in this lecture, but the slides are there for reference. What we're going to talk about in this lecture is other types of colitis, and we're going to start with pseudomembranous colitis. Pseudomembranous colitis occurs as a consequence of Clostridium difficile infection. This is what it looks like on the endoscope, where we have these whitish patches which cling to the surface of the colon. It's due to the surface of the colon being damaged and developing a neutrophil and fibrinous exudate that erupts out of the glands and covers the surface. Why does this happen? It happens because the normal gut flora is altered by broad-spectrum antibiotics. Yes, it requires an abnormal gut flora and then infection by Clostridium difficile. So Clostridium difficile has spores that survive the acidity of the stomach. Where can you find loads of antibiotic treatment and Clostridium difficile spores? The answer is in hospitals. So this is often a complication of patients who are treated with antibiotics in hospitals. It presents with fever, crampy abdominal pain, and diarrhea. And as the bacteria flourishes, it releases toxins that cause mucosal damage and leads to these yellowish plaques and this eruptive neutrophilic and fibrinous exudate on the surface. Next, irritable bowel syndrome. So irritable bowel syndrome is a functional disorder. This doesn't mean that it's a kind of wishy-washy disorder. It creates lots and lots of symptoms and untold agony for people. But we can't see any changes when we biopsy the colon or on colonoscopy. Often it's a diagnosis of exclusion. We exclude inflammatory bowel disease, infection, carcinoma, etc. And these patients still have symptoms, and we call it irritable bowel syndrome. What causes irritable bowel syndrome? It's a combination of things. The gut microbiome, whether there's been a recent infection, the mysterious gut-brain connection, stress, carbohydrate intolerance can all add to irritable bowel syndrome. The most common kind is post-infectious irritable bowel syndrome. So any kind of gastroenteritis will disrupt the microbiome, which can develop into post-infectious IBS. So about 10% of people who have gastroenteritis will develop post-infectious IBS. They typically present with an episode of bacterial gastroenteritis that does not recover, often seen in travelers' diarrhea. Some people will recover from their post-infectious IBS, but it can be a persistent symptom in many people. So how do we classify irritable bowel syndrome? So we classify it often according to the symptoms. All these things are not symptoms of IBS. Change in bowel habits, vomiting, reflux, blood in the stool, unintentional weight loss. these aren't IBS. These are, well, some of them are red flags for colon cancer. So if a patient has unintentional weight loss, blood in the stool, sudden change of bowel habit, do not write it off as IBS. Get them investigated. What we're talking about is abdominal pain, changes in frequency of bowel movements, consistency of stool, urgency, bloating, and distension. Okay, how is it classified? Okay, so we have IBS patients. We've talked about post-infectious IBS, and now we divide it into IBS predominantly constipation and IBS predominantly diarrhea. And the treatment is, as you can see here, aimed at relieving symptoms because we can't really relieve the cause. The cause is unknown. Let's move on and talk about appendicitis. So appendicitis, we've all seen patients with appendicitis, but you can see here that appendicitis strangely has a very wide distribution in incidence rate. We're here, yes, we are on the map, we're here and kind of in the middle for appendicitis. It's a disease that peaks in young people, but can occur at any age. So what do we see with appendicitis? Here we can see this red swollen appendix, and microscopically it's acute inflammation. So of course we see neutrophils that extend through the wall and can extend to the serosal surface. It can be complicated by things like rupture and abscesses. Here is a picture for those of you who love histology, like me. And you can see that here we have an exudate in the center of the appendix, an ulcer, a transmural inflammatory infiltrate which extends right the way through the wall to the serosa. So the problem with appendicitis is that it can perforate, causing pelvic sepsis, and of course the sepsis can lead to the formation of adhesions which can reduce fertility or lead to ectopic pregnancy. Fortunately, these days peritonitis and death are rare because of antibiotic treatment. Here's a quick mnemonic for you to remember what might help you diagnose appendicitis. And there is a MedCalc calculator. You know how I love these calculators that can help you score whether someone is likely to have appendicitis. The other thing that happens in appendixes are neuroendocrine tumors. So neuroendocrine tumors are the most common appendiceal tumor, occurring in about 1% of appendectomies. When we cut up the appendix, we can see this yellow nodule, and it is present mostly at the tip of the appendix. It's usually found incidentally, and there's a great prognosis, 95% survival if confined to the appendix. These used to be called carcinoid tumors, but we call them neuroendocrine tumors now, and we grade them. Most of these are grade 1, low grade, meaning that they will behave in a benign fashion. The other tumor that is associated with the appendix are low-grade appendiceal mucinous neoplasms and high-grade appendiceal mucinous neoplasms or carcinomas. The low-grade appendiceal mucinous neoplasm is associated with pseudomyxoma peritonei. This is when the abdominal cavity fills with a large amount of mucin. What is this mysterious illness? Okay, so the appendix can develop low-grade cells. They look a bit like adenoma cells. They're not horribly, frankly, malignant, but they've definitely got some mutations in them and appear a bit dysplastic. So here we have the appendix mucinous tumor confined to the appendix. It's swollen and forms a little mucinous blob. Often these are discovered at appendicectomy. The cells spread through the wall of the appendix and go into the peritoneal cavity, where they proliferate, forming pools of mucin, and they stick to the sides of the abdominal wall. In late stage, they become much more pronounced, more cellular, and can form large blobs of this low-grade cancer tissue. This disease is hard to cure because it is already round the abdomen, often at diagnosis. Its outcome means that it can progress to a high-grade tumor, or it can lead to lots and lots of adhesions and fibrosis. It has a long disease course, but is often fatal. Now let's think about Meckel's diverticulum. This is the small bowel, and this little blunt pouch here is the Meckel's diverticulum, occurring in 2% of the population within 2 feet of the ileocecal valve, approximately 2 inches long. The rule of twos. Often symptomatic by the age of 2, but most of them are non-symptomatic. They can be lined by small intestinal mucosa, in which case they often just sit there, or by gastric and pancreatic glands. These are the ones that cause trouble because they release hormones, etc., and can ulcerate, giving rise to perforation or just inflammation. Next, we're going to move right down to the other end of the bowel and think about diverticular disease. So diverticular disease is really, really common, particularly in older people in New Zealand. It can be asymptomatic in about 80% of people, and it's caused by a low fiber diet. The low fiber diet causes increased pressure inside the lumen of the distal colon. And that causes these little diverticuli to pop out, right? They pop out through weaknesses in the colonic wall, and the weaknesses occur where the blood vessels go through the muscularis propria. Just like an appendix, it can get a fecalith stuck in it, and this can cause inflammation. And if there's inflammation, that can burst, and we can get an abscess. And the abscess can cause pelvic sepsis and require antibiotics, drainage, or a larger operation. So here we go. This is what the diverticular disease looks like macroscopically. You've got these little blobby outpouchings, often along the tenii, because this is where the blood vessels go in and out. It presents with a classic lower abdominal pain, fever, if it's progressed to diverticulitis, and bleeding, because the blood vessels going into these little pouches can become eroded. And of course, if there's colorectal carcinoma and a change in bowel habit, we need to rule out carcinoma. It can cause fibromuscular thickening, which can cause obstruction, and of course, hemorrhage and infection, as I have just mentioned. Another non-neoplastic bowel disease that's very common is ischemic bowel disease. So ischemic bowel disease is a disease of older people. It can be due to hypoperfusion. In other words, the blood pressure drops so low that the bowel is no longer effectively perfused. This gives rise to a mucosal infarction. Just the inside part of the bowel wall is infarcted. The other type of infarction is vascular occlusive infarction. The most common artery that can be occluded is the acute, is the mesenteric artery. And if this gets occluded, then of course it can cause infarction, and this is full thickness, and this means that part of the bowel has to be removed. Venous occlusion can also occur. Venous occlusion occurs, for example, where there is a hernia, adhesions, or volvulus. This occurs over a few hours, unlike acute mesenteric artery occlusion, which occurs over a few minutes. It initially causes infarction in the mucosa, but if long enough, can cause infarction throughout the bowel wall. Here is a CT of thrombosis of the superior mesenteric vein, which is giving rise to this dilated bowel. It's got very thick walls because of all the edema and congestion that's going on. Here's other common causes of venous outflow obstruction: herniation, volvulus, adhesions, and intussusception. In ischemic bowel disease, where there's transmural infarction due to arterial occlusion, what we get is a very sharp cutoff, maybe with a few extensions because of the arterial segments that are involved. This is most common in the small bowel. Venous obstruction can occur in several areas. Mucosal infarction due to hypoperfusion occurs especially at the splenic flexure and also the other flexures where there is relatively low perfusion of the bowel. What are the complications? Perforation is particularly important with the arterial occlusion and peritonitis. And if there is arterial occlusion, this can lead to septicemia and death. If it's only mucosal infarction, it can heal by fibrosis. People with ischemic bowel disease, arterial, acute, present rapidly with severe constant abdominal pain, and it leads to shock within hours due to fluid loss and sepsis. If a person has mucosal ischemia, they're more likely to have bloody diarrhea. And this brings us to the end of the brief rundown of non-neoplastic GI disease. Thank you.